that everybody's talking. Can I ask everyone to please take a seat so we can get started?
Can you get a shot?
Good afternoon, everyone.
We have her, and I have a
I'm
tag.
Susan Bornstein, and I'd like to welcome you all to Washington and to the Congress. It's wonderful to have you all here. I have the pleasure of introducing our lunch symposium today, which is entitled Osteoporosis Management, the Science and the Art. Before we start, I have a few housekeeping items. First, please take a moment to turn off your cell phones or put them on vibrate. Before we begin the presentation, please take out the green pre-programmed survey that is on your seats. And we need for you to answer the questions on the front of the survey. Do not fill out the reverse side of the survey until after the presentation. Once we finish the presentation, we will take your questions until 1:15, and please use one of the standing microphones in the room to ask your questions. CME or CE credit will be awarded to those who listen to the presentation and who provide a completed blue evaluation form. So you should have a green form and a blue form. And the blue form is the evaluation form that we need for you to turn in order to receive the CE credit. There is no fee to participate or to receive credit. And we would like to thank Amgen for supporting this event through an educational donation. Our speaker today is Dr. Robert Lindsay. Dr. Lindsay is Chief of Internal Medicine at the Helen Hayes Hospital in New York, and he's Professor of Clinical Medicine at Columbia University. A graduate of the University of Glasgow, Dr. Lindsay is an accredited specialist in internal medicine and endocrinology with the Royal College of Physicians, and he's also a fellow of the American College of Endocrinology and the American College of Nutrition. He's authored over 300 journal articles, abstracts, and book chapters on osteoporosis. He's the North American editor of Osteoporosis International, past president of the National Osteoporosis Foundation, and served on the advisory board of the National Institute of Arthritis and Musculoskeletal and Skin Diseases. He has received numerous awards for his research from such prestigious organizations as the American Society for Bone and Mineral Research, the International Bone and Mineral Society, and the National Osteoporosis Foundation. We are very excited to have him here to speak with us today. Please give a very warm welcome to Dr. Robert Lindsay.
Thank you very much, Susan. It's a real pleasure for me to be here and to see so many people interested in women's health. This is what I've done for most of my life. Part of being a lunchtime speaker is to give you some CME stuff, but at the same time, you have to be a little bit entertaining. So now would be a good time to pull out the second half of that talk. And once you've done that, I will then get on with my talk. I can give you the answers if you want as well. So here are the competing interests that I have, and these are our learning objectives for the next 45 minutes or so. We're going to talk a little bit about osteoporosis, and I'm going to talk a little bit about what I believe about osteoporosis, not what the literature necessarily says, or what the common parlance says. But I'm going to talk a little bit about what we're doing right and what we're doing wrong. We'll talk about how to delineate people with osteoporosis, how to get those people who are at highest risk, get them onto treatment, hopefully, and not to treat the people who are not at particularly high risk. We're going to talk a little bit about adherence as we go through that. So everybody knows that this is a pretty common disease. About 30 years ago, Joe Melton said, if you reach the age of 50 and you're a Caucasian female in the United States, you have a 1 in 2 chance of breaking a bone as you get older, almost certainly due to the underlying osteoporosis. So it's very common. But it's not just Caucasian women, it's equally common in Asians, perhaps slightly more common in Asians. It is slightly more common in women of Hispanic descent. And African Americans are the one population where the risk is less, but the risk is still there. the average African American woman at the age of 50 with the current life expectancy that we have has about a 1 in 4 to 1 in 5 chance of fracture. So it's not a diminutive risk in the African American population, but it's just less than that. The problem is that if you look at the Medicare database, only about 20% of people who have a fracture and are on Medicare ever get either diagnosed or treated. I am sorry, I have no control over it. We'll try and turn it up. If I talk from here, it reverberates all over me and I can't hear myself think. So I have to use the lavalier a little bit. Is that better? Okay. So here is where we go wrong. If you ask the wrong question, you don't have to worry about the answers. And in this disease, we spend a lot of time asking the wrong questions, and we spend a long time listening to those answers. So that's where we're going to start. So here's question number 1. For persons with osteoporosis, should only fractures that occur in modest trauma be considered osteoporotic? Who believes that is correct? Nobody. Wonderful. All right, I can go now. Thank you very much. It's been nice talking. Here are the answers to that question. Fractures are never osteoporotic. Only bones are osteoporotic. Fractures can occur because of osteoporosis. And a person with osteoporosis is at risk of fracture, any fracture, with the exception of fingers, toes, and skull, because skull fractures, as we know, tend to occur in young teenagers doing stupid things. The level of trauma that is needed to fracture a bone when you've got osteoporosis is lower than it is in the general population. But that means that on high levels of trauma, you are more likely to fracture. And yet we dichotomize fractures into low trauma fractures and high trauma fractures. And when someone comes to the emergency room with a high trauma fracture, nobody ever thinks about whether or not there's an underlying bone disease. There's somebody coming to the emergency room with chest pain, make the diagnosis of myocardial infarction. Well, why should we measure this? It's the same problem. So here we are, the fracture, the amount of trauma that is required to measure to treat a fracture. Here you see it up here. Here you see it up here. Here is what it takes to fracture osteoporosis. Much less trauma. But the person who has a high level of trauma, even if they've got osteoporosis, they will still fracture and fracture more likely to fracture. If you take a 70-year-old woman with osteoporosis, put in a car going 50 miles an hour, and run that car into a wall, she's going to fracture. But the fracture will be treated and actually sent home. Nothing much more will happen as a consequence of that. Here's question number 2. You can only have osteoporosis if your bone density falls below the normal range. T-score of minus 2.5 as is quoted on the diagnostic as a diagnostic threshold for osteoporosis. Another question for which the answer is no. We do diagnose osteoporosis by bone density. We've equated people who fall below the normal range as having osteoporosis and being a high enough risk that we should treat them. But we also diagnose it based on fractures. As I said, fractures sometimes happen in people who don't have osteoporosis by bone density. But let's take that person who's got a T-score of minus 2.5 and who we're going to make the diagnosis. What if a T-score of minus 2.4? It could be on a different day, on a different machine. Do you think the risk is any different? If it's a real difference between minus 2.5 and minus 2.4, the risk is essentially the same. So why should we make an arbitrary cut point? What we really need to do for the population of people who think that are most of osteoporosis is to define their risk of fracture, because that's what we're trying to avoid. We're trying to avoid anything like fracture. We've dichotomized it this way. Here you see a family of curves relating bone density to the likelihood of over a 10-year period of getting a fracture. And you see that 50-year-olds at any level of bone density are at a lower risk than 60, 70, and 80-year-olds. But we've dichotomized them to those with osteoporosis in that blue box, and then we sort of dismissed everybody else above that. We're going to come back to that graph in a little bit. So here is my speculation in all of this. Osteoporosis is really an architectural problem. It is a change in architecture in the skeleton that causes deteriorating capability to resist trauma. got nothing to do with density. We don't even measure density. We call it density, but it's not density. What we are trying to estimate is whether or not our skeleton has normal architecture. Unfortunately, we have to use the surrogate of density because we have no easy way at present of defining the architecture of the skeleton. Then there are other things that happen. As we get older, there's an increased likelihood that we can injure ourselves. We're more likely to fall, balance becomes less. So we put ourselves at risk of fracture as we get older, unless we maintain our
Leave it on the sides. Like we just have to add
Notice
just
that
have to
there's
add
a marathon
up
on here tomorrow.
until they stop serving.
I'm going to count how many people in this room go out and run that marathon.
You can't. She wants
Maintain
us
your
just to
physical
jack it
activity. I
up.
tell people all the
Just
time,
because.
when they ask me what to do, I
Jack
say,
it up just because.
two rules. Do something you like, because then you might actually do it. And make it a social occasion, because that'll keep you doing it. Beyond that, I really don't care what people do for exercise. I just want people to exercise. So this is osteoporosis. On the left, you see normal trabecular bone in a scanning electromicrograph from our group. And on the right, you see osteoporotic bone. And I'm going to highlight 3 bits there. 2 bits on the bone and 1 on the leg of the stool. What you see in the 2 bits of bone are horizontal trabeculae that have become disconnected from their other end. Disordered architecture. These trabeculae are not providing any support anymore because they're only connected on one end, but they are also providing mass. And that's what you're measuring that makes this such a difficult thing to do. If I take my 3-legged stool, the 3 legs are held together by 3 horizontal struts. I take one of those horizontal struts out. What's going to happen when you sit in that stool? It's going to collapse. Probably collapse without you sitting on it. But it certainly will collapse if you do sit on it. I cross a bridge across the River Hudson every day, a bridge called the Tappan Zee Bridge, which you guys probably don't know, but they're talking about rebuilding the Tappan Zee Bridge. It must be 50 years old, and it looks about 150 years old. And it's rusting and horrible and nasty. And I keep thinking, if I pull a couple of horizontal struts out of that bridge, I'm not going to make it to the other side one day. That's osteoporosis for the Tappan Zee Bridge. That's why the bridge is up there. So when should we actually start to get worried about this? Well, the guidelines tell us that everybody who is female should have a bone density done when they get their Medicare card in their hand. At the age of 65. Medicare will pay for it. Well, that's recognized. Then when would you do it in younger people? You might do it in younger people. Postmenopausal women. If you think they're at high risk, we're going to come back to that in a little bit, especially at risk. For premenopausal women, please do not do bone density unless you really have to, because you're going to end up in a horrible, horrible problem. And that's going to be the focus of what I talk about tomorrow. It's bad enough we give you once a week to give you place. If you have somebody who's premenopausal and they fracture on something that you think would not be a reasonable amount of trauma, that's the reason to do bone density. Somebody who's got multiple sclerosis, anorexia nervosa, comorbidities are reasons for doing bone density in premenopausal women, but otherwise in healthy women do not do it. So here's what we get out of the bone density report. Thanks for sending Mrs. Smith for bone density. She's at age 60. Her T-score is -2, which increases her fracture risk by 4 times. That is the most useless piece of clinical information you're ever going to get. The reason is it doesn't tell you anything about risk. It tells you relative risk. But in order to understand relative risk, you have to know what the baseline risk is for the population. You're not told that. 4 times what? You don't know. There's nothing there that tells us 4 times what. But if we've got a convenient retrospectoscope, which is one of the most valuable scientific instruments in society, then we know that at age 40, the bone density T-score was +1, and she's lost bone. So I'm now going to define Mrs. Smith at age 60 with a T-score of -2 as having osteoporosis, because the architecture of her skeleton has become deranged because her bone density has been down from +1 T-score to -2. But here's another lady. She's now Mrs. Jones. Same age, same T-score. But my retrospectoscope now tells me that she actually had that T-score when she was young. Her bone density hasn't changed. So So who is at greater risk of fracture? Versus the lost bone or this lady? Well, the answer is that they're both at high risk of fracture. The first lady is at risk because she's lost bone. She's got an architecturally deranged skeleton. The second lady is at risk because she's probably small and slim. And small bones break more easily than large bones. That's not an advertisement for obesity, rather. Don't take it wrong. Being small and slim is wonderful when you're 25. By the time you become 60 or 65, it becomes problematic. Because small bones, like pencils, break more easily. Just take that pencil and snap it. Take that pencil and make it 2 inches thick. Now try and snap it. That's much harder to do. There is nothing we can do about small bones. We can't change the size of the skeleton. But what we can do is reduce the risk of fracture. And that's what treatment is all about. Let's make Mrs. Jones now 85 years of age. Now she gets a T-score of -2. Now at this age, she's at very high risk of fracture because her age has increased. And going back to my earlier family of curves, here is Mrs. Smith and Mrs. Jones. Look at the difference in absolute risk of fracture between the lower line, there, and the upper line there. At the same level of bone density, the older individual is at greater risk of fracture, requiring intervention at higher levels of bone density. In other words, what I've done is taken that away from that relative risk into absolute risk. The likelihood that something bad is going to happen over a horizon in this year, 10 years. There is a model available for that. It's been built, but there are several models built for that. The most common one is called the Fracture Risk Assessment Tool, or FRAX. To have X at the end of it means the unknown quantity, because there's still some things we don't know. And if you get fracture risk assessment, it tells you the likelihood of having a fracture over the 10 years. It uses some common risk factors, it uses bone density, and it tells you whether something bad is going to happen or not. That's a useful tool because then you put the onus on the person on the other side of the office desk to say, I'm either willing to accept that risk or I want you to do something about that risk to reduce it. It becomes a logical and reasonable argument at that point. So this is what should now be the report on the bone density that you get. Given Mrs. Smith's age, fracture history, weight, cigarette use, family history, and bone density, our estimated risk of fracture in the next 5 years is 25%. That's a measurable risk. A 1 in 4 chance of something breaking in the foreseeable future. And now Mrs. Smith can then say, okay, I'm prepared to take that, or I want you to do something about it. What we've done essentially is taken our vertical box called osteoporosis and turned it horizontally and made it into a high fracture risk domain. In the United States, it is considered to be cost effective to intervene if somebody has a 10-year risk of any fracture of 20% or a 10-year risk of hip fracture of 2%. There are many people who will accept that as a reasonable risk and say, I don't want treatment because I've heard bad things about the medicines that you use. And there are other people, and I come from New York, as you heard, where there are a lot of slightly insane people living. And they will say, I don't care how small the risk is, I want you to do something about it, doctor. And that's fine, if that's what they want. But they have to now realize what it is really they're doing. We'll come to that. Going back to the problem, the clinical community is still not equating fractures in the older population with osteoporosis. It's a traumatic incident. And making that cut point of -2.5 doesn't capture most of the people who have a fracture. And it's difficult to identify people above that -2.5 just by looking at them to decide whether or not they're really going to fracture. Here are data from the study of osteoporotic fractures. And you have to forgive me, I put this slide together and it shows you my incapability with PowerPoint. But the green bar shows you the distribution of the population in this. These are 65-plus-year-old women being followed for osteoporosis risk. You have to multiply the scale by 10 to get the total number of figures. It's not 160 at the top, it's 1,600. The distribution of hip fractures is shown in yellow. On that slide, it looks slightly green. And it basically is yellow. And you'll notice that The red dividing line tells you where osteoporosis is. So everything on the left has osteoporosis by bone density. Everything on the right does not. There are a lot of hip fractures occur in people who don't have osteoporosis. And yet we accept hip fracture as the worst fracture of this disease. Everybody gets a hip fracture has, by definition, now osteoporosis. But they don't have osteoporosis by bone density. So why don't we treat all the people who don't have osteoporosis by bone density? Because we have to treat thousands in order to reduce the risk of one fracture if you just globally did that. That's why it becomes important to do risk assessment. And here is the tool that is used. If you Google FRAX, F-R-A-X, you will get to this page. Actually, you get to a page before this. It has a very nice picture of Dr. Canis on it. You see the originator of this. And if you look at this looks at a bunch of risk factors. It looks at age, it looks at gender, it looks at race, and it looks at smoking history, steroid use, rheumatoid arthritis, other secondary causes of osteoporosis, excessive alcohol use. And of course, this was made up in Europe, so it's 3 units of alcohol is excessive in Europe. Sometimes. Not from where I come from. And then you hit the little button after you put bone density in, and it calculates the risk. And here we've got a lady whose risk is relatively low and would not need treated as a consequence of assessing risk by FRAX. I'll talk a little bit about the ethnic differences in bone density. There are very significant differences in bone density. These are 2 slides from Elizabeth Barrett Connor's work looking at ethnic differences. And there's part there related to the differences in body weight, ethnic differences in body weight. But there are also ethnic differences in absolute fracture risk. And it was remained beyond that. Here you see the data that I talked briefly about before, looking at fracture risk across the ethnic groups. And we've set the risk here for the Caucasian population as 1. And you can see that the African American population is essentially half that risk. The Hispanic population is slightly greater one, and the Asian one also slightly greater than 1. So there are clear ethnic differences, and when you do that risk classification, you can pull down something that allows you to look at Hispanic, Asian, African American. You will get a different result depending on the ethnic group you choose. So what about people who present with fractures? Why are we missing all these people? These are the people at highest risk. There are a lot of data that say that. This is looking at prevalent vertebral fractures as a function of risk. And you see the people who have prevalent vertebral fractures in 4 different studies here have a higher risk of fracturing during the course of the study, whether they're on medicine or not. So getting a fracture is bad, increases your risk. These are data that we put together from the placebo arms of a bisphosphonate set of studies, in which we carefully looked to see who would have a fracture in 1 year, and based that on whether or not there was a prevalent fracture at baseline. So first of all, we looked at prevalent fracture, and people that have prevalent fracture were more likely to fracture. And we said, well, what happens if they have a fracture during that first year? What happens subsequently? And subsequently, the people with an incident fracture, a new fracture, had about a 20% chance of fracturing again within the next 3 years. We extended those data and looked at any fracture over a 5-year period, and it comes out to 40%. Having a fracture is a harbinger of having another fracture. And that's why we have to get into the risk assessment tool. Bones break when the load exceeds the strength of the bone. And low bone density and architecture contribute to the strength, but there are other things that contribute to load. How do we load our own skeletons? Our weight, our frailty index, our fall capability to fall. People are recurrent fallers or non-fallers. Recurrent fallers are going to break. Nutritional status, comorbidities, medicines, the list goes on and on and on. And so you have to look at fracture as combining osteoporosis as a diagnosis, inherent bone disease, with the other things that increase the risk of fracture. And these can be divided into treatments and injury prevention strategies. Reducing fall risk, this is something that people talking about osteoporosis never actually give much attention to. But it is critical, because if you let people fall, as I said, they will break, and they will break whether or not they're on medicine. So cut down the medicines that people are getting. especially sedatives. There's nothing worse than somebody really being given a sedative and then being given hydrochlorothiazide. Okay? I don't even need to say any more. You're all visualizing this frail lady getting up in the middle of the night and being unable to find the bathroom. And she falls on her way, breaks her. Monitor antihypertensives for the same reason. Postural hypotension causes you to fall. Ensure an adequate vitamin D intake. Vitamin D is the vitamin of the decay. Every disease known to man, woman, and child is related to vitamin D insufficiency. I see an awful lot of postmenopausal women, and my favorite story is, you know, vitamin D insufficiency has been associated with a reduction in the risk of C-section. You guys got it a lot faster than most of my patients get it. They sit and look at me and go, what? And then you realize at 65 years of age, they're no risk of getting a C-section. You have to take the vitamin D data with a healthy pinch of salt, because most of the data are observational. Where vitamin D has been shown in clinical trials to be effective is improving muscle tone and strength. People with osteomalacia or rickets have a proximal myopathy, and they fall a lot, and they waddle when they walk. People who are frail and elderly waddle when they walk. If you improve the vitamin D status, you improve the gait. You reduce the risk of falling. Therefore, in controlled clinical trials, you reduce the risk of breaking a bone. And it's dead easy to treat. You go to Costco, and for $10, you buy a year's worth of vitamin D. You can't get any medicines that are much cheaper than that. I used to measure vitamin D levels in everybody. I don't do that anymore. I just give everybody 1,000 or 2,000 units of vitamin D. Vitamin D economy, incidentally, is also racially related. African Americans have a different vitamin D economy and a different calcium homeostatic system than Caucasians, which is one of the reasons they protect themselves from osteoporosis. At any given level of calcium intake, they have a lower urinary calcium. Our economy is better than it is in the Caucasian population. Exercises, I keep coming back to that. I put Tai Chi up in here, you put Zumba in there, you can put anything. Americans completely run dance classes now. It's great. Then never forget about the fact that you can't see, you can't hear, you're going to fall. Try to be hearing and see. And using proper footwear. When someone comes to see you in slippers, okay, they're going to fall, or they're going to get the slipper caught in the escalator out there when they go back to the meeting. So it's important that you check this thing. That's why medicine is such an art rather than a science. You have to look at the person sitting there in the office with you. No matter what your role is in medicine, you have to look at the person, you have to talk to the person, and you have to correct these things that are easy to correct. Sort of like what you hope they do with the airliner before you get on it. Somebody looking for microtracks. Somebody looking for a whole fracture. Because you don't want that plane to fall out of the sky with you in it. Right? And that's essentially what you're trying to do with the patients that come see you. You're trying to ensure that their bodies, they've got a healthy body and a healthy mind. So what do we do for treatment? Well, background treatment is calcium and vitamin D. Calcium you should get from your diet. It's not difficult. Total intake should be 1,000 to 1,500 milligrams a day. A glass of milk would be 300 to 350 milligrams. Dead easy. Green leafy vegetables are full of calcium. Yogurt, anything. Most of what we eat has got some calcium in it. Even red meat has calcium in it. It's not difficult to get 1,000 to 1,500 milligrams. That does not mean that everybody needs to take a supplement of 1,000 to 1,500 milligrams a day. That gives them a surfeit of calcium. If you're not getting enough calcium in your diet, you will remove it from your skeleton. If you're getting enough calcium in your diet, you will remove much less from your skeleton, but the extra that you're taking doesn't do anything for you. And there are some data that suggest that it might increase the risk of cardiovascular disease. So total intake should average 1,000 to 1,500 milligrams a day. For vitamin D, as I said, we get 1,000 or 2,000 units to virtually everything. So this is the calcium controversy that I just went through. If you eat too little, you get bone loss, and that's usually said to diets of less than 800 to 1,000 units a day. Calcium intakes above that may be harmful. However, just this month, there was a paper from an Australian group, from Alicia Suarez, that said, well, it might help control weight. Okay. So if your patient wants to figure out how much calcium they're getting, send them to the NOF website. National Osteoporosis Foundation website. It's a little calcium calculator. And they can calculate their average intake of calcium pretty easily. It's an easy way to do it. Vitamin D, as I said, the vitamin of the month, or the year, or the decade. A lot of data say that vitamin D does have actions in multiple parts of the body, including the brain, and that's why I take a lot of vitamin D. But remember, most of the studies are observational, and the Institute of Medicine recommendations, I think, are probably set a little too low, especially in New York during the winter. Well, maybe not this winter, but mostly. And there's some data again from the Australian group this month that said that insulin sensitivity might be improved if vitamin D levels are adequate. A lot of interesting stuff coming down the pike about that. So there's a large study in the United States underway to try and evaluate the non-skeletal outcomes of vitamin D. My personal feeling is that it's going to be tough to demonstrate that, but we'll see. So when you consider pharmacological intervention, go back to my fracture risk calculation again, about 20% is considered cost-effective, risk of hip fracture about 3%, and then anybody over the age of 50 who presents with a long bone fracture, typical osteoporosis-related fractures. Classically, that's the hip, the spine, and the wrist. It also includes the humerus and the pelvis. These are classic osteoporosis-related fractures. And then, bone density osteoporosis. And I put a little bit of a question mark above it there, because not everybody with bone density osteoporosis really needs intervention. The 55-year-old healthy woman who happens to be 100 pounds and 4 foot 11 and a half, although she claims 5 foot, she doesn't need it because her bone density should be low. She doesn't need intervention. She will need it later on in life, but at 55 she probably does not. So if you take these NOF guidelines and you look at what we would do with it, we'd actually treat about 1/3 of the postmenopausal population in the United States. And that's, I think, a very large number of people. Now, we are treating close to that number, but we're not essentially targeting the highest risk group. And that's really what this is all about. For non-Hispanic, African-American women, it's about 11% that we should be treating. So how well do we understand the treatments? Well, we actually know a little bit about the medicines, but we don't know enough about the medicines for us to practice medicine in the way that we're asked to, which is evidence-based. Because for many of the medicines that we have short-term evidence, but we're being asked to use those medicines long-term. And there's very little long-term evidence, and that's where we run into problems. All of those medicines reduce bone remodeling, they reduce bone formation, they reduce bone resorption, they stabilize bone mass. That's essentially what they do. One that's different is teriparatide. Teriparatide improves bone mass and architecture. But most patients won't require long-term therapy, so how do you pick them? Well, here's what we have. Background calcium and vitamin D, everybody should get that. Hormone therapy coming back a bit since WHI. And estrogens are very clearly important in controlling skeletal homeostasis. And they're important not only in women, but they're also important in men, something that's commonly not well understood. You can eliminate androgens from men, give them estrogen, and they won't lose bone. You can eliminate estrogen, you can give them all the androgen you like, unless it's converted into estrogen, they will lose bone. So estrogens are just as important in men as they are in women. And then we've got the bisphosphonates and one right ligand inhibitor. And you notice I've divided these into the ones that reduce all fracture risk and the ones that have been shown in clinical trials prospectively to reduce just vertebral fractures. And the reason that I do that is that you might choose one or other depending on what you think the risk is. If it's somebody who's at high risk of vertebral fracture, you can choose any of those medicines. If it's somebody at high risk of non-vertebral fracture because they've got a low hip bone density or they've had a non-vertebral fracture, you want to use something that will be effective in all fracture sites. So here are the data. I borrowed this slide from Dr. Nelson Watson a number of years ago. I borrowed it from Steve Brunin in Europe. And what it shows is the Non-vertebral fracture efficacy for a variety of treatments. The one on the very left is the non-vertebral fracture efficacy of estrogen from WHI. Estrogen is just as good as everything else as far as the skeleton is concerned. There are other issues which we all know about. And then we see bone, which is the Vandernick study, Moore, which is the Valoxifene study, and then we've got several with bisphosphonates, Risedronate, Alendronate, and Zoledronate. Tell me which one of those drugs is better than any of the others. How do you practice evidence-based medicine? You pick your poison, and you go through the pros and cons of each of those medicines, and you hope you're doing it correctly. Remember, the first thing that we're taught in medical school, first, do no harm. And that's tough to do when there's very little evidence about what you're doing. So bisphosphonates, for example, have been concerns about esophageal cancer. That came from the Food and Drug Administration first. It seems to be disputed and doesn't seem to be real. Osteonecrosis of the jaw comes up, common in cancer patients, but less common in people with osteoporosis. But the big worry is the appearance of subtrochanteric fractures. This is what osteonecrosis of the jaw looks like. It occurs usually after a dental procedure, and its clinical diagnosis is failure to heal exposed bone over an 8-week period from the time that it was first seen. There's quite a lot of elderly people when they're getting tooth removal or implants prepared. But it also occurs in people on osteoporosis medicines. Whether there is a cause and effect relationship is far from clear, because in osteoporosis this lesion is really quite rare. The American Society for Bone and Mineral Research estimated that it was about 1 in 10,000 to 1 in 100,000. It really is rare. My colleague John Bilaziki and Ed Cyrus put it together in the following way. Here's your risk on the top of any fragility type fracture: hip fracture, anaphylaxis, death from a motor vehicle accident, death by murder, and osteonecrosis of the jaw. The risk is said to be exactly the same as the risk of getting struck by lightning if you live in New Mexico. Now, I know all my patients are not going to move to New Mexico because they're scared of the lightning strikes. Right? But my concern is more these subtrochanteric fractures. Now, the reason that I am concerned about it is that the hospital that I spend most of my time in, Helen Hayes Hospital, is actually a rehabilitation hospital. And so we collect those fractures. And that's one of the worrying things. And now there's some data from the VA system that says that they're not really related to bisphosphonates, right? But we really don't know very little about them. You know why? Because they are peculiar fractures. Let me show you one of them. This is the lady that I first saw with these subtrochanteric fractures. She was 59 years of age. She went through menopause roughly about the age of 50. She told her gynecologist she was having nothing to do with estrogen because WHI had just come out. The gynecologist said, "My dear, you need to be on something to protect your bones." So they put her on bisphosphonate, and she religiously, she says, took it every week. Never went back to the doctor, just kept it refilled. Slipped a little bit in the supermarket on a puddle and did the fracture that is on the right as you're looking at it. This x-ray was taken 6 months after that fracture occurred and after the pinning was done. There's very little callus there. 3 months later, she had gone through rehab and gone home, and she was walking with a walker because it was still very painful to walk on that leg. And she stumbled, and she fell. She fell around. She stumbled, and what she heard was a crack on the other side. And that was the fracture on the other side. At 59, this woman was made disabled. And that sort of sits with me as problematic, and I don't really know what to do about it. The FDA went through this in September of last year and said, the advisory committee said, well, maybe we ought to think about drug holidays, but we don't really know how to do that, when to do that, and if we should do it. But we do drug holidays, but if you do a drug holiday, you can monitor it. Why? Because these drugs, the bisphosphonates, last for a long time after you stop them sometimes. And as long as you can show suppressed bone remodeling biochemically, you can probably safely leave that person off the drug. These fractures are uncommon, however. These are data from my colleague Jerry Nevis, published 2 years ago in Osteoporosis International, looking at the frequency of hip fracture. And you'll notice that from 1996 to 2006, the frequency of hip fracture is going down. We must be doing something right. It's going down. But the frequency of subtrochanteric or femoral shaft fractures is not changing. Still only about 1/10 the risk of a hip fracture, but it's not really changing. That's true in both men and in women. How did it happen? We don't know. We don't know whether it's related to bisphosphonate. Potentially related to reductions of bone turnover, perhaps related to incorporation of the bisphosphonate into the crystal. You get large atypical osteoclasts in bone when you give bisphosphonates. We don't know what they do, but they may be incorporated in this. And some people have suggested, well, it's not really the drugs, it's the patients. Maybe they've got some heterozygous condition that leads to a skeleton that's likely to break. We don't really know, except that most of our people are on bisphosphonates. One drug that doesn't get into bone that's anti-resorptive is this one, denosumab. Denosumab stops rank ligand, receptor activator for nuclear factor kappa B. That's on the second page of the form you have to fill out. Denosumab stops you making osteoclasts. And it works very well for a 6-month period, and you get a reduction in fractures as a consequence. Here's the fracture data from that. You see non-vertebral fracture, vertebral fractures, and hip fractures all reduced, the same as the bisphosphonates. So the data are very similar. You get a marked reduction in fracture risk. It doesn't get into the skeleton, and so one might argue that if it's the bisphosphonate getting into the skeleton that's important for those subtrochanteric fractures, we will not see it for this drug. But we don't know yet. We don't have long enough data, and we don't have enough people treated for a period of time. These are the adverse events that are seen with denosumab. And the reason that I put them up is that if you ever try and use denosumab and your patient actually reads the package insert, they'll never take the drug. The list is about this long. And the first one that's up there is back pain. Back pain occurred in 1,347 people on denosumab and 1,340 on placebo, a difference of 7. But because of that difference of 7, it has to be in the package insert. It's very hard to explain to patients that these are not necessarily real adverse events, but sometimes statistical quirks of the data. Anabolic agents, we only have one in the United States, teriparatide, 184 parathyroid hormone. The full-length peptide is available in Europe. And Europe also has strontium granulate. And you notice I put that down as unclassified. I don't know how strontium granulate reduces fracture risk, but it does seem to. And many of your patients will now go to the pharmacies in the United States and buy off the shelf strontium chloride, strontium citrate. In the trials in Europe on strontium granulate, the dose of strontium is about 600 milligrams a day. Strontium, not strontium granulate, it's 2 grams a day for strontium granulate. I don't know how much people would take strontium would take, but strontium replaces calcium within this crystal, so it makes heavy bone. And that's really maybe the mechanism by which it is reducing fracture risk. You see a small decline in bone resorption, a small increase in bone formation. You don't know what that means. Teriparatide, however, is the only drug that repairs the architectural damage that I talked about. What you see here are 2 iliac crest bone biopsies from our group looking at the before and after from the same person. One on the left has a lot of holes in it, one on the right is architecturally more sound. And you see the increase in cortical width that occurs with teriparatide. It does replace the damage. The concern, of course, is that teriparatide in rodents is associated with osteosarcoma. One doesn't really know whether that is the case in humans as yet. So who should get teriparatide? Well, you reserve it for the people who are at highest risk of fracture for 2 reasons. Actually, 3 reasons. Firstly, the osteosarcoma issue. Secondly, it's very expensive, and insurance companies don't like it. And thirdly, it's a daily subcutaneous injection. A lot of patients don't like that. You have a lot of needle-phobic people, and they won't do it. We're only supposed to use teriparatide for a maximum of 2 years in any lifespan. So we use it for a year, then we stop, and use an anti-resorptive agent after that to try and keep compliance going, and reserve the second year should we happen to need it again. Often, however, we see people already on medicines. Should they get teriparatide? Probably, if they have a fracture while they're on treatment. Seems a reasonable approach. But then what do you do with the underlying treatment, bisphosphonate? If you change, then you don't get as good a response than if you use both drugs together. But in today's economic climate, trying to use 2 drugs for the one disease like that without good data is fractured area is very difficult. And so we don't really know what to do and research and change. Now, why do these people not stick to their medicines? Well, money, costs. The capability to increase co-pays based on the cost of the drug and have patients pay a fraction of the cost rather than a $20 co-pay, which, if they pay a fraction of the cost, which for teriparatide can be $300 or $400 a month. The drug costs about $800 a month. So it can be very costly. And then osteoporosis tends to get eclipsed by other things. Oh, I don't want to get a heart attack, I'm going to die. You don't want to get a hip fracture, you're probably going to die too, but people don't realize that. And then concern about side effects. Everybody wants the magic bullet. Nobody wants to take a medicine that's got side effects. Very simple principle, every medicine that you use has side effects, period. If you find a medicine that has no side effects whatsoever, it probably has no effects either. And then poor patient education. We have really failed to educate people as to what we're trying to do. And that's our fault, it's the fault of society, it's the fault of organizations like the National Osteoporosis Foundation. And we're about to start and try and do it again. Trying to tell people that what we want to do is stop fractures are bad. And then sometimes the medicine disrupts their daily routine and they can't be bothered with it taking. How many people have taken a 10-day course of antibiotics and at the end of 10 days have got tablets left? All the time. Trying to take medicines on a long-term basis is not. And then we don't have a very good way of giving positive reinforcement. Rate of bone density, which you can do after 1 year, you can put somebody on treatment, or 2 years later. I called a medical director of an insurance company and said, I'm going to give you a medicine. You won't know whether it's doing anything or not. And I'm going to ask you to get tested 2 years after you started. And that 2 years after you started it, I'll be able to tell you whether it's doing anything or not. And he down the phone, I didn't tell him what medicines I was talking about. Down the phone, he said, you have to be crazy. Nobody's going to do that. I said, that's what every postmenopausal woman in your planet has been asked to do. They've been asked to do it because they said, the insurance company said, biochemical tests that we do, biochemistry of bone turnover is for research only and it won't cover it. Biochemical tests have been FDA approved for 10 years, still trying to get them covered by all insurance companies. So, ending. The future belongs to those who believe in the beauty of their dreams. Peter Bruegel looked at it this way. He wanted people to age successfully and really be good looking until the day that their final demise. That's what we would all like. Unfortunately, Toscani saw it a different way. And believe it or not, that's really how a lot of people look at themselves. They have poor body image. Body image, which is a construct that we have all inside ourselves, is based on our psychology and our own view of our health, often leads us to look or to think, imagine that we look like this. This is a table of life expectancy in a variety of countries. At the same time, we have health expectancy. That is, how long somebody expects to live and be healthy, and then they die at a later age. Look at the big difference in the United States data from the Canadian data. Canadian life expectancy, 73. Health expectancy, 67 years, a difference of 6. In the United States, it's 70, 55, a difference of